Welcome to the fifth day of discussion of your GIT. And today we are going to cover a major aspect of your gastrointestinal system, a very important part. This part is going to be. So we are going to discuss about the upper GI hemorrhage, number one. And number two, we are going to, after completing the upper GI hemorrhage, we are going to discuss about the bowel obstructions and all those small intestinal diseases. That is very important from your exam point of view. So take a screenshot. These are the important questions that can be asked in your exam. I have just written it down. Okay, so we'll just continue from this place. Okay, so let's start with the first one, upper GI hemorrhage. What is upper GI hemorrhage? Upper GI hemorrhage is nothing but bleeding proximal to the ligament of teres. So when you call it as a upper bleeding, or when do you call it as a upper GI hemorrhage? We call it as upper GI hemorrhage when the bleeding is going to be proximal to that of the ligament of teres. Okay, when there is going to be proximal to that of the ligament of teres. Okay, so you're going to have a very important things here. So what we are going to discuss basically is going to be, we are going to discuss about the causes. We are going to discuss about the cause of this bleeding. Okay, what are the causes of bleeding? Then we are going to discuss about what are going to be the prognosis of this bleeding. What are the different types of bleeding? Everything we are going to discuss in detail. So let me start with the first one. It is going to be upper GI hemorrhage. It is going to be a upper GI hemorrhage. This upper GI hemorrhage can be divided into two. One is non-variceal bleeding, and other is going to be your variceal bleeding. Okay, either you can have variceal bleeding or you can have non-variceal bleeding. What are the causes of your non-variceal bleeding? Non-variceal bleeding, it can be due to number one, it can be due to peptic ulcer disease, which is the most common, and number two, it can be due to gastritis. Okay, number one, peptic ulcer disease, number two, gastritis, and number three, it can be due to cryptosporidiasis. Okay, especially in the AIDS patient. Okay, so these are the non-variceal bleeding causes. Okay, these are the non-variceal bleeding causes. So what are the causes of a variceal bleeding? We'll talk about it later. Non-variceal bleeding, number one is going to be a peptic ulcer disease. Number two is your gastritis. Number three, cryptosporidiosis in a HIV patient. And number four is going to be a Mallory V-steer. So number four is going to be a Mallory V-steer. Number five, it's going to be gastric antral disease, vascular ectasia, gastric antral vascular ectasia. And number six is going to be your Menetrier's disease. Okay, so what are the six again? Repeat along with me. Peptic ulcer disease, gastritis, cryptosporidiosis in HIV patient. Then you have your gastric antral ectasia, gastric antral vascular ectasia. Then you have Mallory V syndrome or Mallory V steer. Then you have Meniere's disease. Okay, so there is going to be different types of gastritis. When I tell about the gastritis, when I tell specifically about gastritis of different types. Okay, so let me tell you about the types of gastritis that is asked as a short note for you all. Gastritis is going to be of four types. Gastritis is basically of four types. Okay, it's going to be type A, type B, type C. Type C is nothing but stress induced. So usually type C is nothing but your stress induced. And number four is going to be your NSAID. It is going to be your NSAID induced. Okay, let's discuss one by one. So let me tell about the type A. Disease. What is type A? Type A is an autoimmune gastritis. Okay, so it's autoimmune gastritis. Why it is occurring? It is going to be occurring, okay, due to autoantibody against your parietal cells. Here what happens? There is going to be a autoantibody against parietal cells. Note it down, guys, along with me. Parietal cells. Okay, and this is going to be causing achlorohydria. This is going to be causing anemia. What type of anemia it is going to cause? It is going to cause pernicious anemia. These are the four types of A. So type A la 4A நீங்க நான் வச்சுக்கணும். என்னென்ன 4A நான் வச்சுக்க போறீங்க? It's autoimmune type, achlorohydria, anemia, autoantibody against parietal cells. So இங்க இன்னொரு ஒரு பாயிண்ட் நீங்க நான் வச்சுக்கணும். Okay, what is the other thing which you are going to remember here? This is going to be occurring in the body of the stomach. Let's move into the type B. So what is type B, guys? Type B is a bacterial disease. So bacterial induced. What bacteria mainly? Helicobacter pylori. So Helicobacter pylori is the one that is going to affect, and which part of your stomach is going to involve here? Antrum is going to be involved here. So type A, autoimmune disease. It is going to be affecting your body of the stomach. There is going to be anemia. What type of anemia? Pernicious anemia. And this is going to be having achlorhydria. So it's autoantibody against your parietal cells. Now coming here type B. Type B is going to be due to the H. pylori. H. pylori enga affect panno, antrum affect panno. Okay. Number 3 type C is nothing but I told you already. It is going to be stress induced. So it's going to be a stress induced. I am writing in a different color because this is very important. Stress induced, there can be two type of stress. Okay, so there are two type of stress you can have. One thing is going to be due to some burns. Okay, number one, they can be due to some burns. Number two, it can be due to some head injury. It can be due to some head injury. Or number three, it can be due to a mental stress. So, மூணு important conditions-லையுமே உங்களுக்கு stress ulcers வரும். அதனால தான் during your exam preparations, you will be having mouth ulcers, you will be having stomach pain. All these things are going to be due to the stress ulcers. So, burns. So, in burn injuries, first part which is going to get involved is your first part of duodenum. First part of duodenum is going to be the first part which is going to get injured. Okay, this is going to be the most common. And this ulcers, we call with specific name. The name is going to be Cushing's ulcer. Cushing's ulcer. When I was studying final year, there was 2 marks for us. And in the 2 mark, most repeated question is this 2. Cushing ulcer, curling ulcer. Mati kepanga. So these two are very important from the exam point of view. Next is going to be head injury. Again, I am telling you, in head injury, there is going to be acid. Okay, there is going to be head injury. What happens basically is, in your head injury, acid producing area of the stomach will be getting overactivated. So this is going to be acid producing area of stomach overactivated, and that can lead to ulcer called as Cushing's ulcer. That is called as Cushing's ulcer. Okay, these two things I want you to remember. And finally, the fourth type is going to be your NSAID induced. NSAID induced. And recently what happened is, there is one more type they added, that is going to be your AIDS type. So one more type they added, that is going to be your AIDS type. AIDS type la who is going to be the culprit? Cryptosporidia. So he is a culprit. He is going to cause a problem. Okay, now we are moving into the individual discussion. The first one, Mallory Weiss tear. What is Mallory Weiss tear? A very, very important question. This is most common. This is most common in alcoholic patient. It is most common in the alcoholic patient. It is going to be occurring after a bout of, forceful vomiting. So forceful vomiting pandrappa, what happens in this is, there is going to be a tear of mucosa or submucosa. There is going to be tear of mucosa or your submucosa. So tear of mucosa or submucosa from your gastroesophageal junction, up to cardia, So there is going to be a tear of mucosa, submucosa from your gastroesophageal junction up to your cardia. That is called as Mallory Weiss tear. Again, repeat along with me, guys. Number one, it is very common in the alcoholic patient after a bout of forceful vomiting. The tear is going to occur in the mucosa, submucosa of your gastroesophageal junction up to your cardia, and the vessel that is going to be involved here, is going to be your left gastric artery. Now the question arises, how do you differentiate this Mallory Weiss tear from your the previous one which we have discussed in your esophagus? That is going to be your Borroway's syndrome. In Borroway's syndrome, there is going to be a tear perforating. So perforating tear na Borroway's syndrome. Adu alcoholic patient la varum. But Borroway's syndrome vandu pathina, it is nothing but it is a perforating disease. So I want you to remember that. Don't forget. So Borroway's disease is going to be also occurring in your alcoholic patient, also occurring after forceful vomiting. There is going to be a perforation that leads to chest pain. That is a clenching feature of differentiation. You have chest pain and you have subcutaneous emphysema. Okay, that is called as Mackler's triad. So what is that triad called as? Mackler's triad. Whereas in your Mallory Weiss tear is also alcoholic, a bout of forceful vomiting, tear in the mucosa, submucosa of the gastroesophageal junction up to cardia. Vessel implicated here is going to be left gastric artery, and this is going to be a self-limiting disease. So this is going to be a self-limiting disease. Next, we are going to discuss about the GAVE. What is GAVE? Gastric antral vascular ectasia. So what is gastric antral vascular ectasia? This is going to be a dilated venules present in the antrum. It's autoimmune disease. This is going to be a autoimmune disease, which is going to be presenting in the dilated vessels of and dilated venules. Okay, in a vessel, dilated venules. Okay, so it's autoimmune disease. Dilated venules are going to be there. Very important. This is associated with the collagen vascular disease. I want you all to note this point very importantly. A newly added point in your Bailey and Love. It is associated with collagen vascular disease. Collagen vascular disease. This is very important. And also remember endoscopy. When you're going to put and if you're going to see in endoscopy, what you can see is watermelon stomach. You're going to see watermelon stomach. That is very important. Okay, it's going to cause watermelon stomach. And what is going to be your management for these patients? In these patients, what is going to be your management? You're going to go for argon photocoagulation. Okay, very important. Argon photocoagulation பண்ணுவீங்க. And now moving on towards the next disease, that is going to be your Meniere's disease. So we will complete Meniere's disease. After Meniere's disease, I also wanted to discuss about this one important condition that is called as Dilephois lesion. Dilephois lesion is asked as a 2-mark question when I was there. So now what they can do is they can give you a simple question. They can ask you what are the different causes of upper GI hemorrhage. That can be asked as a question, and you will be needing to write individually about all those things. So in short way you can write, that's enough. So now coming back to the next one, that is going to be your Meniere's disease. Meniere's disease. What is Meniere's disease? It is going to be occurring due to the overexpression of your TGF alpha. Overexpression of TGF alpha will lead to Meniere's disease. And what happens here is there is going to be a hypertrophy. There is a hypertrophy of gastric mucosal folds. Okay, very important. So Meniere's disease, it is going to be due to the overexpression of TGF alpha. Hypertrophy of gastric mucosal fold had occurred. Hypertrophy of gastric mucosal fold has occurred. And what is going to be the earliest feature? Very important. What is going to be the earliest feature? Earliest feature is going to be your protein losing enteropathy. Okay, protein losing enteropathy. What is going to be your investigation of choice in this patient? Investigation of choice is going to be your endoscopy. You go for endoscopy. That is the investigation of choice. And what is the problem here? It has a risk of malignancy. There is a high risk of malignancies. And what is going to be your management for these patients? Management is going to be very easy. Cetuximab. So cetuximab, why do you give cetuximab? Can someone tell me why do you give cetuximab? Cetuximab is a monoclonal antibody. It is a monoclonal antibody against what? Against EGRF. Okay, epithelial growth factor. Okay, receptor. It is going to act against the EGFR. Okay, against the EGFR. Therefore, cetuximab is given. And if they serve them, okay, if in a very severe case, if their case is going to be very severe, then what you are going to do in severe cases, you go for a gastrectomy. Very, very important. You go for gastrectomy. This is what important. This is what I want you all to remember. Okay, now coming towards the last and final part of your upper GI bleed, which I wanted to discuss, is going to be the Dilephois disease, Dilephois lesion. What is this Dilephois lesion? Dilephois lesion. Now it is a dilated submucosal artery. So Dilephois lesion. Now it is a dilated submucosal arteries. Dilated submucosal arteries, which is going to be more common in male. Okay, male than your females. Okay, it's going to be more common in male than your female. And lesions are similar to angiodysplasia in colon. So what happens? Lesions are going to be similar, okay, to your angiodysplasias in your colon, dysplasias in the colon, very important. And you will also see this most commonly in the elder age group. So இது என்னது பேசிக்கா? This is a dilated submucosal artery, which is most commonly present in the male. I want you to remember, most commonly present in the male than your females. Lesions are going to be very similar to that of angiodysplasia in colon, and this is going to be present in the elderly age group. I told you already. Okay, and clinically it is going to be presenting as a upper GI hemorrhage, அதான் present பண்ணுவாங்க. And what you're going to do for this patient management, you're going to give a coagulation of vessels. That is going to be your management. Coagulation of vessels are going to be the management for this patient. Is this clear, guys? Let's see certain images and then come back to the variceal breathing. Okay, now we are going to talk about the variceal bleeding. Okay, so what is this? Can someone tell me what is this? This is your, what is this? This is your Mallory-Weiss tear. So this is going to be your Mallory-Weiss tear. Can you remember? Mallory-Weiss tear. Okay. And what is this? Can you see this? This is going to be looking like or what does this look like? This looks like a watermelon. Okay, this looks like watermelon. So we call it as watermelon stomach, seen in the gastric antral vascular ectasia. And what is this? This is the gastrectomy specimen of cerebriform convulsion. மாதிரி இருக்கு. இது என்னது? This is your Menetrius disease. This is going to be a Menetrius disease which you need to understand. Okay, hope you remember. Next, we are going to move towards a very important topic, that is going to be the variceal GI hemorrhage. So variceal GI hemorrhage la you have what you have to remember is two important things. Okay, first I will talk about the prognostic scoring. So what is this prognostic scoring called as? Prognostic scoring, we call this as, okay, AIM 65. What is this AIM 65? So AIM 65 na enna? Edha nama kurikirom? Can someone just recall and tell me in the chat box? Patient comes to you with a GI hemorrhage. So AIM 65 is nothing but this is going to be a simple score. It is going to be a simple risk score. Okay, which is going to predict. It's going to predict the mortality rate in patients with upper GI. It's going to be predicting the mortality rate with upper GI hemorrhage. This is a very important thing, guys. I want you all to remember. What is this AIM 65 full form? I'll tell you one by one. AIM 65, AIMS. Just put like this. A stands for albumin, which is going to be less than 3 gram per deciliter. So that is one. And I stands for INR when it is going to be more than 1.5. Then M stands for mental status alteration, and then S stands for systolic BP less than 90 millimeter of mercury, and finally 65 stands for age more than 65. This is the first scoring system I want you all to remember as far as your hemorrhage is concerned. So first ஒரு patient உங்ககிட்ட வந்தாங்கன்னா score them out of 5. Okay, we are going to score them out of 5. Seri score பண்ணிட்டேன். Next நான் என்ன பண்ணும்? What is going to be my outcome of this? So outcome is going to be very simple. When the score is more than 2, is a high risk patient. It is going to be high risk patient. So the patient is going to be having a high risk. You are going to diagnose. You are going to suspect high risk from this prognostic scoring. Next, we are going to see is going to be your again another prognostic scoring which we are going to see. This prognostic scoring is going to be your scoring for hepatic venous portal gradient. It's a prognostic value of your hepatic venous portal gradient with chronic liver disease. So when the hepatovenous portal gradient, how you are going to measure this hepatovenous portal gradient? HAVG ன்னு சொல்றோம்ல, இதை எப்படி நீங்க மெஷர் பண்றீங்க? You're going to measure this by Doppler. You're going to measure the Doppler by Doppler. What you're going to measure? You're going to measure portal hypertension. You're going to measure the portal hypertension by Doppler. So Doppler la measure பண்றீங்க, அப்புறம் gradient பாக்குறீங்க. When that is going to be 1 to 5 millimeter of mercury, it is normal. When it is going to be 6 to 10 millimeter of mercury, it is a preclinical sinusoidal portal hypertension. Preclinical sinusoidal portal hypertension. When it is going to be more than 10 millimeters, this is going to be a very important. When they're going more than 10 millimeters, they are clinically significant portal hypertension. They are going to be clinically significant portal hypertension. And when it is going to be more than 12 millimeter of mercury, increased risk of rupture, increased risk of rupture of varices. Okay, இப்போ rupture ஆயிடுச்சு, இன்னமும் உங்களுக்கு ப்ரெஷர் அதிகமாகவே இருந்தது, ஆல்மோஸ்ட் 16 வரைக்கும் போச்சுன்னா, தட் காஸ் 16க்கு மேலே போச்சுன்னா இன்க்ரீஸ் ரிஸ்க் ஆஃப் டெத், மொர்டாலிட்டி. அண்ட் மோர் தேன் 20 if it goes, mortality is confirmed, treatment has been failed in the acute variceal bleeding. This is what you have to remember. This is what you have to remember. Okay, will you remember? Yes. Next we are going to move towards what are the causes of the liver failure. What are the causes of your liver failure? Okay, just put the heading as liver failure. We will check, we will discuss what are the causes of liver failure. Number 1, prosthetic. Okay, it's going to be post. Okay, we are going to discuss 3 things. Number 1, we are going to discuss about the pre-hepatic condition. Number 2, we are going to discuss about the intra-hepatic condition. Number 3, we are going to discuss about the post-hepatic condition. What is pre-hepatic condition? Pre-hepatic condition na portal vein innu vandu pathina they haven't entered. Okay, they haven't entered into your after collecting from your mesenteric vein. So mesenteric vein, it is going to be collecting, it is going to become, isn't it? Do you remember the blood supply? Do you remember the venous drainage of your GIT? Venous drainage of GIT. Someone, guys, someone. Venous drainage of GIT. Come on, you can just put in the chat box. Venous drainage of GIT. Yes, exactly. So what happens? Veins from your portal venous system, systemic venous system, portal venous system, systemic venous system, ingella vandu pathina ungalku sila connections irukku. Okay va? What happens basically, you're going to have your superior mesenteric vein, you're going to have inferior mesenteric vein. What happens? Your inferior mesenteric vein along with your splenic vein, inferior mesenteric vein along with your splenic vein, it is going to come, both are going to be joining with your superior mesenteric vein, and they are going to continue as a hepatic portal vein. This hepatic portal vein is going to enter inside your entire lungs. Okay va? So in the my lungs ku enter agadhukku munnadi, okay, what are the things you have? You are going to have 2 important things. You are going to have your pre-hepatic vein. Hepatic veins la enna irukku? Your mesenteric vein, superior mesenteric, inferior mesenteric. Along with it, you are going to have splenic vein. Whenever there is going to be any thrombosis in your portal vein, portal vein gather superior and inferior mesenteric vein join on one another, or whenever there is going to be a thrombosis in the splenic vein. Okay, whenever there's a thrombosis in the portal vein, whenever thrombosis in the splenic vein, thrombosis. Okay, portal vein thrombosis and splenic vein thrombosis, it leads to pre-hepatic liver failure. Okay, so what are the causes of intrahepatic? Intrahepatic, again we can divide into 3. Okay, by intrahepatic, again we can divide into 3. What are the 3? Number 1, pre-sinusoidal. Pre-sinusoidal, number 1. Number 2, you're going to have sinusoidal. And number 3, you're going to have as a post-sinusoidal. So you're going to have pre-sinusoidal, sinusoidal, and post-sinusoidal. Pre-sinusoidal, what are the causes of pre-sinusoidal? Number 1, idiopathic portal hypertension. Number 1. Number 2, primary biliary cirrhosis. Number 2. Number 3, sarcoidosis. Number 3. And number 4, you're going to have schistosomiasis. So I'll repeat one by one. Number 1, idiopathic portal hypertension. Number 2, you're going to have idiopathic portal hypertension. Number 2, you're going to have primary biliary cirrhosis. Number 3, you're going to have your schistosomiasis. Number 4, sarcoidosis. What are the causes of the sinusoidal? Sinusoidal, you're going to have number 1, alcoholic cirrhosis, alcoholic hepatitis, okay, post-necrotic cirrhosis, and number 4, you're going to have your post-sinusoidal. Okay, post-sinusoidal enna varudhu? Sinusoidal obstruction syndrome. Sinusoidal obstruction syndrome. So these are going to be the various causes. And post-hepatic la vandu pathina ungalku romba easy. You're going to have your Buchighari syndrome. Buchighari syndrome idella neenga vandu medicine la padipeenga. Buchighari syndrome. Number 2, you can have constrictive pericarditis, or you can have inferior vena cava obstruction, or when there is going to be right heart failure. All these are going to be post-hepatic causes. Okay, so now we have discussed about the AIM 65 criteria. Then we have discussed about the prognostic value of HVPG in patient with a chronic liver disease. So what is going to be the significance? Can you just tell me if it is going to be 1 to 5 millimeter of mercury, 1 to 5 millimeter of mercury, this is going to be normal. Okay, so what we are discussing? We are discussing about the HVPG. We are discussing about the HVPG values. We are going to discuss about the HVPG values. When it is going to be 1 to 5 millimeter of mercury, it is going to be normal. When it is going to be 6 to 10 millimeter of mercury, it is going to be preclinical sinusoidal portal hypertension. Preclinical sinusoidal portal hypertension. And number 3, you're going to have more than 10 millimeter of mercury, more than equal to 10 millimeter of mercury. It is going to be clinically significant. Okay, portal hypertension. And number 4 is going to be more than or equal to 12 millimeter of mercury. More than 12 millimeter of mercury, it's going to be increased risk of rupture of varices. Okay, this is going to be the 4 important prognostic index which you need to remember. And now we are going to move towards portal vein thrombosis. Okay, we are going to talk about certain important things that are going to be number 1, portosystemic shunt. So portosystemic shunt, enganga in the shunt nadakudhu? Can someone tell me where is this portosystemic shunt is going to occur? So we are discussing about the portosystemic shunt. What happens? Where does you get this portosystemic shunt? So basically, portosystemic shunt, now you're going to have your left gastric vein. So you're going to have left gastric vein. Then you're going to have short gastric vein. So this left gastric vein and short gastric vein are going to get anastomosed. Okay, left gastric vein, short gastric vein. So they both are going to get anastomosed. Short gastric vein, left gastric vein, both are going to get anastomosed. So this is going to occur in the distal esophageal vein. So this is going to form the distal esophageal vein. Okay, distal esophageal vein oda anastomose agudhu. So you have your left gastric vein, short gastric vein, both are going to get anastomosed with the distal esophageal vein at the esophagus. This is going to form esophageal varices. Okay, number 1. Then you're going to have what? You're going to have coronary veins. And along with it, this is going to get anastomosed. Coronary veins are going to get anastomosed with the azygous and hemiazygous. It's going to get anastomosed with the azygous and hemiazygous. Okay, that is going to be the second one. So first, we have different portosystemic shunt. That is what I'm explaining. Number 1, esophageal varices. Number 2, you're going to have your coronary vein getting anastomosed with the azygous and hemiazygous in the vertebral venous plexus. And what is going to be the number 3? Number 3 is going to be your splenic vein. Your splenic vein is going to get anastomosed with your left renal vein. That is going to be the third anastomosis. And what is fourth anastomosis? You're going to have left gastric or gastroepibloic vein, which is going to get anastomosed with the esophagus. Again, esophageal and paraesophageal vein. Esophageal and paraesophageal vein. Okay, it's going to get anastomosed with the esophageal and paraesophageal vein. And this is also going to form esophageal varices. Yeah, இதெல்லாம் important. No, all these things are the one that causes upper GI hemorrhages. So இப்போ நம்ம பார்த்துட்டு இருக்கிறது upper GI hemorrhage. So this portosystemic shunt and this shunt both are going to give rise to what so-called upper GI hemorrhage. So that is what we are discussing here. Okay, so then we have discussed about certain important things right here. So let's see one by one. Number 1, we are going to see about we will see about this portal vein and splenic vein thrombosis. So what happens? Listen to me carefully. No need to write. Portal vein thrombosis is extrahepatic portal venous obstruction. This is commonly seen in the first and second decade. There is a cavernous changes that is going to be held in your portal vein or web. So this can lead to 2 important conditions. One, fulminant இது வந்து acute present ஆச்சுனா liver failure cause பண்ணும். Gradual இருந்ததுனா that is going to lead to portal hypertension and splenomegaly. Number 1. Number 2 is going to be a splenic vein thrombosis. Specific splenic vein thrombosis என்ன பண்ணா left sided portal hypertension cause பண்ணும். Usually secondary to acute pancreatitis, management is going to be your splenectomy. Non-cirrhotic portal fibrosis. What is non-cirrhotic portal fibrosis? It is going to be mainly in the 3rd and 4th decade. It is going to be seen mainly in the 3rd and 4th decade, very important. And what you need to remember here is going to be no cirrhosis, no bridging fibrosis is going to be present. So there is no cirrhosis, there is no bridging fibrosis that is present. No cirrhosis and no bridging fibrosis present in this condition. So what you're going to remember, guys, no cirrhosis or no bridging vein thrombosis is going to be present. No cirrhosis, no bridging vein thrombosis is present. So management is going to be nothing but transplantation. Then your Buchiari syndrome. Buchiari syndrome, segment 1 hypertrophy, Buchiari syndrome. It's going to be hepatic venous outflow occlusion. Cause of occlusion, either it's going to be prothrombotic or web in your outflow vessels. Either prothrombotic or because of the web in the outflow vessels. So now you have different causes. Number 1, pregnancy, protein C deficiency, which is typically seen in the females. Clinically, gradual course, fulminant course. Gradual course can cause abdominal pain, portal hypertension. Fulminant course, again, it can lead to fulminant liver failure. Now we are going to move towards what are going to be the clinical features of the portal hypertension. What are the clinical features of portal hypertension? Clinical features are, number 1, okay, liver failure. Number 1, you're going to have caput medusae. Caput medusae. You're going to have caput medusae. Number 2, there can be ascites. There can be ascites. Number 3, there can be splenomegaly. Splenomegaly is going to be there. And number 4, you're going to have is your liver failure. So there is going to be liver failure. Now, how do you manage the patient? So how do you manage this patient? So let me talk about the management of your variceal bleeding. So management, always remember, you first go anything emergency, you go for the ABC management. ABC. First one, ABC management you're going to do. After doing a ABC management, next what you're going to do is, next you're going to go for IV agents. IV agent and fluids. IV agents and fluids. Remember, guys, what you have to remember here is, so there's an increased chance of aspiration. Okay, so increased chance of aspiration airway first manage pandrenga. Breathing. So breathing again you're going to find the alternate arrangement. After completing your breathing, what happens? There is going to be your circulation. Circulations IV fluid போட்டுறீங்க. IV fluid போட்டதுக்கு அப்புறம் blood matching கொடுத்துருங்க. IV agents கொடுத்துருங்க. So most common drug which you are going to use is going to be your octreotide. So remember, so most common you use is going to be your octreotide. But best, if you are going to ask me, best is going to be your IV terlipressin. Terlipressin is the best one and not used. Which is not used? That is going to be a beta blocker. IV propranolol. IV propranolol is not used. Very important. So PPI you are going to give only after endoscopy. Remember, PPI you are going to give only after endoscopy. This is very important point. So PPI you should give only after endoscopy. Okay, so now what you're going to do, you're going to see whether patient gets stabilized. So patient gets stabilized on paakringa. Once the patient gets stabilized, what you're going to do, you go for upper GI endoscopy. Upper GI endoscopy pandringa. So upper GI endoscopy la what you're going to see, number 1, you're going to see banding. So banding, okay, banding pandringla more common than your sclerotherapy. Banding, which is more common than your sclerotherapy. So I'll just write it properly. Banding, sclerotherapy. Okay, so banding, which is done more common than your sclerotherapy. Sclerotherapy na enna sclerotrant, which is going to be used. So sclerotic agent which is going to be used is going to be your sodium. So which is going to be used? Sodium tetradicyl sulfate, which is going to be the most common sclerotherapeutic agent which is used. Okay, so ipo enna pandrenga, in the sclerotherapy irukilla, this can be used for 2 things. Okay, so sclerotherapy rendu vishayathukku pannalam. Banding adhe maari. First I'll talk about the sclerotherapy, then we can go for the banding. Sclerotherapy, which is going to be most commonly used, this is going to be controlling bleeding. So for controlling the bleeding you're going to use, okay, bleeding control. And second, bleeding control enna பண்ணுவீங்க, once bleeding is controlled, you're going to discharge the patient. So எப்படி discharge பண்ண போறீங்க, you're going to give propranolol. So you're going to give tablet propranolol. Okay, so IV tablet oral after discharge you can give. If it is going to rebleed. So what you're going to do? So now you are in a very critical situation. You are trying to control the bleeding, but bleeding is not stopping. So again, what you're going to do? You're going to go for a second attempt. So you're going to again attempt for GI bleed, again attempt for endoscopy. But unfortunately, if you bleeding nikkelana, you go for TIPSS. That is what we are going to talk today. That is going to be your TIPSS. Let's discuss about TIPSS. Okay, before that, we will talk about this banding also. So I think I told you something about banding, isn't it? I told something about regarding your banding. Okay, remember when you're going to tell about this banding. So we are going to do TIPSS. Okay, so TIPSS பண்ற வரைக்கும் நம்ம வெயிட் பண்ணணும். ஓகேவா, பேஷண்ட்டை நம்ம TIPSS பண்ற வரைக்கும் we have to wait. ஓகேவா, so this procedure you can actually follow for both the things, guys. Okay, bandingக்கும் யூஸ் பண்ணலாம், ஸ்க்ளீரோதெரபிக்கு யூஸ் பண்ணலாம், அதேதான். ஸோ ப்ளீடிங் கண்ட்ரோல் ஆகுதா இல்லையா அப்படின்னு தான் நீங்க பாக்குறீங்க. Okay, so what happened is you're going to wait for TIPPS, right? So till you take patient for TIPSS. Okay, temporarily you need to stop the bleeding. So temporarily you need to stop the bleeding. How we are going to stop the bleeding temporarily? By using 3 important tubes. I think I will be showing you all the tubes also now. Okay, you have 3 important tubes. What are the 3 important tubes? Number 1, you have your Sengstaken. Okay, Blakemore. So இதெல்லாம் உங்களுக்கு வைவால வைக்கலாம், இல்ல உங்களுக்கு examல they can ask you what is Sengstaken Blakemore tube. What is Sengstaken Blakemore tube? It is going to have 3 channels and 2 balloons. It is going to have 3 channels, 2 balloons. So this is going to control the bleeding. Okay, next is going to be நீங்க now வச்சுக்க வேண்டியது 3 channels இருக்கும். It is going to have 2 balloons. Okay, then you're going to have second thing, that is going to be Minnesota tube. What is this Minnesota tube? It is going to again have 4 channels. It is going to have 4 channels, and this 4 channels will be having 2 balloons. Okay, 4 channels and 2 balloons. Okay, next is going to be your Linton tube. It's going to be Linton tube. What is Linton tube, guys? Linton tube is going to have 3 channels again, similar to that of a Sengstaken Blakemore tube, but it is going to have only 1 balloon, in contrast to that where you're going to have 2 balloons. Okay, so what is this balloons are going to do? They are going to compress the area of bleed and they're going to stop the bleeding. Okay, let's see the images. So can you see here? So this is going to be your, what are the different causes of your liver failure? I have told you already. And this is going to be your caput medusae, the appearance of distended and engorged superficial epigastric veins, which are seen radiating from your umbilicus across your abdomen. And this is going to be your balloon tamponade devices. This is your Linton's device, Sengstaken Blakemore tube, and your Minnesota tube. So in Sengstaken Blakemore tube, you're going to have 2 balloons. Can you see here? This is your gastric balloon. Then you're going to have esophageal balloon. And this Minnesota balloon, Minnesota is also going to have 4 channels and 2 balloons. Can you see here? You're going to have 4 channels here, and you're going to have 2 balloon here, esophageal balloon and your gastric balloon. Whereas in your Linton's tube, you're going to have 3 channels, gastric suction part, gastric balloon inflation part, esophageal suction part, and you're going to have only 1 balloon, that is going to be a gastric balloon. Okay, so this you need to remember. Now we are going to move towards the tips. What is tips? Trans is jugular intrahepatic portal systemic shunt. What is tips? So it's a transjugular intrahepatic portosystemic shunt. Okay, this is a shunt that is going to be present between the portal vein and your hepatic vein. Can you see here? So there is going to be a shunt. This is your shunt. That shunt is going to be present between your between your portal vein and your hepatic vein. So there is a shunt that is present between your portal vein and hepatic vein. There are various complications for it. Let's start with it. So first one we're going to discuss is TIPSS. What is TIPSS? Transjugular intrahepatic portosystemic shunt. Okay, it's going to be portosystemic shunt. That is your TIPSS tips. Okay, so what you have to remember is you're going to place a shunt which is going to be between your portal vein and your hepatic vein. So you're going to place a shunt between your portal vein and your hepatic vein, portal vein, and your hepatic vein. Okay, wow. So what are going to be the complications which are going to be arising? Complications are going to be early complication, rupture of capsule A. Early complication is going to be rupture of capsule. What is going to be your most common complication is going to be blockade. So the most common complication is going to be blockade. This leads to rebleeding. Very important. And this is going to be non-selective. So non-selective shunt. Okay, this is a non-selective shunt, and since it is a non-selective shunt, it is going to give rise to encephalopathy. Very important, guys. These are the complications of your transjugular intrahepatic portosystemic shunt. There are other shunt also. There are different types of shunt basically. Number one, you're going to have a selective shunt. What is selective shunt? You're going to have selective shunt is going to be Warren's. Okay, distal splenorenal shunt. Then you have Inokuchi. Inokuchi is left gastrovenocaval shunt. So what is going to be the advantage of selective shunt? Remember, selective now selective two example I'm going to tell you. One is your Warren and other is going to be Inokuchi. So there is going to be advantage of this. What is going to be the advantage for this? Shunt is going to be only for splenic vein. It's going to be only for splenic blood. Okay, it's going to be only for splenic blood. And this is going to splenic blood, and this is going to avoid encephalopathy. It avoids encephalopathy. So number one, shunt only splenic blood. Number two, it is going to avoid encephalopathy. And you're going to have second thing, non-selective. What is this non-selective? Non-selective, you're going to have again two. One is your Linton. Linton is proximal splenorenal shunt. So Warren is a distal splenorenal shunt, whereas Linton is proximal splenorenal shunt. And you have Inokuchi, left gastrovenocaval shunt. And what is X fistula? X fistula is a portocaval shunt. X fistula. Okay, so this they are going to have a risk of encephalopathy. So more common risk of encephalopathy is going to be present in your non-selective. Okay, non-selective more common. Okay, so this comes to the very important end of your shunt. Now we have a certain scoring system. Now I'll tell you one scoring system. This is also a very important scoring system. I'm going to tell you actually 2-3 scoring system continuously. First scoring system, a very important scoring system is going to be your child puke score. Okay, child puke score. Ingiyum papenga. Child puke score you will be seeing again in your. You're going to again see while you're going to talk about the liver separately. So liver pati nama pesarappa, again you will be talking, I will be telling you about the child puke scoring. Now also I will tell you about the child puke scoring. Why I am telling 2 times? Because when I am going to tell 2 times, that means it is very, very important. Child puke scoring is very, very important. Okay, let's discuss about this child puke scoring. So child puke scoring basica on the pathagana. It is going to have certain factors. What are the factors it is going to have? Number one, it is going to have encephalopathy. Okay, child puke scoring is going to describe the encephalopathy. It is going to tell about it is going to tell about the it's going to tell about the ascites of the patient. Okay, encephalopathy. Then it is also going to talk about the ascites of the patient. So can you see here? This is your child puke scoring. So encephalopathy, it will be talking about the ascites. It is going to talk about the albumin presence. It is going to be talk about the bilirubin, and what are the other component? Prothrombin time. Okay, prothrombin time is also a component. So you have 5 important components: albumin, encephalitis, okay, ascites, prothrombin time. Prothrombin time seconds prolonged or so you can either go for your INR. So this is a table taken from your surgery textbook, Bailey textbook. Bailey textbook gives it as a INR, but whereas in your Harrison, if you go, it goes and talk about the IA. It is going to go and talk about the prothrombin time also. Okay, so in your prothrombin time include panala, but again prothrombin time is also included in your child puke scoring, which is given in your Harrison textbook. Okay, so child puke scoring learning, and now it's going to be ரொம்ப simple. When the child puke score is going to be 5 to 6, okay, it is going to be least. When it is going to be 7 to 9, it is going to be moderate. More than 10 to 15, it is going to be severe. Okay, so this is one classification which I want you all to remember. So next another classification is going to be prognostic scoring in upper GI hemorrhage. So upper GI hemorrhage already or prognostic scoring. Can anyone tell me what is that prognostic score which we have already discussed? One prognostic score which we have already discussed. Yes, that is your AIM 65. So do you remember we have discussed about the AIM 665? That is going to be a prognostic scoring for your upper GI mortality rate. Another one, there is going to be a mortality rate described pandra another scoring system that is called as bleed. Remember like this, bleed. B stands for ongoing bleeding. So bleeding that is going to be occurring, that is going to be the first one. L stands for low systolic blood pressure, and E stands for elevated prothrombin time, and E stands for erratic mental status, and finally D stands for any comorbid diseases. Okay, comorbid diseases other than your bleeding. Okay, so this is going to describe about the prognostic index of your upper GI hemorrhages. And finally, you're going to have another one that is going to be your Forest classification. Forest classification is going to be based on the endoscopy. So it is going to be based on the endoscopic classification. So classification. So what you're going to do is you're going to go for an endoscopy. Endoscopy பண்றப்ப ஒருவேளை spurting bleeding இருந்ததுனா, that is classified as 1A. If there is a oozing bleed, you classify it as 1B. In the 1A, 1B there is a high chance of rebleeding. After the 2A, non-bleeding, just visible vessels are there. 2B, there is an adherent clot. And 2C, there's a flat spot in the ulcer crater. That is going to be 2C, and 2A, 2B, 2C is going to have moderate risk. Whereas clean base ulcer, if it is present, that is a stage 3, that is going to be having a very, very less chance of rebleeding. I've given images down. Okay, next you're going to see this is going to be a shunt, a different shunt. This is going to be a Werner shunt. So you asked me, right, what is Werner shunt? What is this and all? So Werner shunt, what I told you, what is a Werner shunt? Werner shunt is a distal spleno-renal shunt. Can you see a spleno-renal shunt? That is your Werner shunt. What happens in your portocaval shunt? Portosystemic, direct caval anastomosis. This is going to be a Mitra shunt without splenectomy. Okay, right? So then you have another one staging. This is called as Rockwell scoring system. Rockwell scoring system, just remember one thing. Rockwell scoring system is also another prognostic index. So which is going to consider age, comorbidity, shock, source of bleeding, and recent bleeding any history. So this is going to be your what is this called as Rockwell scoring system. Next, you are going to have another one scoring system that is called as Glasgow Blatchford score. So there are three Glasgow scoring pathirkom. One Glasgow coma scale, இன்னொன்னு Glasgow outcome scale. So Glasgow outcome scale enga paathom? Head injury. So whenever there is going to be a trauma, we will be having one scoring system that is called as your Glasgow coma scale, Glasgow outcome scale. So that's a brain death patient. So when you're going to have a brain death patient, what you're going to do, you're going to check for the and the scoring system Glasgow outcome scale, Glasgow outcome score. So Glasgow outcome score. So it's a prognostic scoring following the head injury. It's a prognostic scoring following head injury. Again, the same outcome score, it is also used in case of appendicitis. Okay, appendicitis operation the scoring, prognostic scoring, Glasgow outcome scale. In the Glasgow Blatchford scale, it is a scale which helps in identifying the patient with upper GI may be safely discharged from your emergency room. So what I think you're going to consider again here, number 1, you're going to consider systolic blood pressure. Number 2, heart rate. Number 3, hemoglobin. Number 4, blood urea nitrogen. Along with it, melena, syncope, hepatic disease, cardiac disease, melena, and syncope. These are the 4 Glasgow Blatchford scoring. Okay, this is very important. And next is going to be, we are going to talk about the small intestine. With this, we are completing a very important topic that is going to be your liver. We have completed upper GI hemorrhage. So upper GI hemorrhage next we are going to discuss about the small intestine. Small intestine, do you remember I told you to take a screenshot initially? potentially. So in that screenshot, I have described what are the important questions that will be asked from your exam point of view. Do you remember? So what are going to be the questions that can be asked in the exam point of view from your this particular important discussion? That is going to be your, yes. So we are going to have 10 important points which you are going to discuss in the next coming session. That is going to be bowel obstruction, radiological signs that are going to be present. First stricture where you are going to visualize intersusception. We are going to see sigmoid valvulus, Merkel's diverticulum, SMA, superior mesenteric artery syndrome. Then you have Hirschsprung disease, mesenteric ischemia. All questions important questions that is having a potential point to be asked in your exam. Okay, so potentially they can be asked in your exam. Therefore, you are going to have a very, very important thing here. So what we are going to discuss now. Shall we begin, guys? Do you want any break? If you want break, take a 5 minutes break, pause the video, go back and then come back again. Then come back. Let's discuss about the bowel obstruction now. Okay. Yes. So I hope so you all took a break. You have come back. Now we are going to discuss about the bowel obstruction. This bowel obstruction is a very, very important question, guys. Okay. So what happens? So bowel obstruction can be of two types. Okay. Number one, either it can be a dynamic type or it can be a dynamic type. What is this dynamic type? So you're going to have a bowel like this. So what happens is there is going to be obstruction like this. So dynamic when there is a physical obstruction to the flow of feces. This is going to be your feces. Okay, so on feces இப்படி போகிறதுக்கு இங்க வந்து பாத்தீங்கன்னா there is an obstruction. So that is called as your dynamic obstruction. Remember, dynamic obstruction when there is a physical obstruction to the flow of feces. What is adynamic obstruction? Adynamic there is no physiological obstruction. There is no physiological obstruction. In spite of that, the feces cannot pass. Why? Because there is going to be a non-contractile bowel wall. Non-contractile bowel wall. Okay, there is going to be a non-contractile bowel wall. Remember, so dynamic, adynamic, dynamic there is obstruction. There is going to be obstruction in your small intestine, which is going to be preventing your feces passage. What is adynamic? Adynamic is a non-contractile bowel wall presence. Adynamic, non-contractile bowel wall is present. So what happens in your dynamic? Dynamic number one, there is going to be hyperperistalsis. So நம்மளோட smooth muscles of your intestine என்ன பண்ணும்னா it will try to push out your feces outside. It will try to push out the feces outside. If they are trying to push out the feces outside, they have to contract very much. They have to increase the contraction. So there is going to be a hyperperistalsis. Okay, there's going to be hyperperistalsis. So this can be heard as a hyperperistaltic bowel sound in the dynamic obstruction. If there is going to be still, this obstruction is going to be persisting. When the obstruction is going to be persisting, this persisting leads to perforation. It can lead to perforation. Very, very important. Okay, so perforation, if there is a perforation, that will be having a silent abdomen. That leads to silent abdomen. ரொம்ப important. Okay, so hyperperistaltic bowel sound in the dynamic obstruction, if it is going to lead to a perforation or strangulation, that can lead to silent abdomen. Now coming back towards your adynamic. In adynamic, what happens? It is going to be silent from the beginning. It is going to be silent from the beginning. It is going to be silent. This is what I want you all to remember. It's going to be silent from the beginning. Now coming back towards what are the clinical features that is going to be present in the bowel obstruction. Number one, there is going to be a non-passage of flatus and feces. There is a non-passage of flatus and feces going to be present. That is going to cause obstipation. So obstipation and constipation, abnormal non-passage of your feces. Flatus non-passage going to have your obstipation. ரெண்டுமே சேர்துல flatus feces. I know you call it as obstipation, and you're going to have vomiting. Very important symptom. Vomiting is going to be there. You're going to have distension of abdomen. Then you're going to have your abdominal pain. You can have abdominal pain. Okay, these are the four important things, four important cardinal symptoms. They can give this as a obstipation. Obstipation na exam la enna theriyama irukadinga. Obstipation na non passage of flatus and feces. So order of appearance may be varying according to the site of obstruction, but ultimately these are going to be the four important clinical features which are going to be present. Now we are moving on towards the investigation. Remember, investigation of choice, which is going to be investigation of choice. Investigation of choice is going to be in the adult, it is going to be CECT, whereas in children, it is going to be USD, children like USD. But remember, another important thing is what is going to be the initial investigation. Initial investigation need not be investigation of choice. Initial investigation அப்படினா patient உங்ககிட்ட வர்றப்ப நீங்க என்ன investigation எடுக்க போறீங்க, that is going to be X-ray abdomen. You're going to take X-ray abdomen, erect or supine. Okay, erect and supine. Basically erect and supine you can take. Okay, so what is going to be the investigation of choice in adults? It's going to be CECT. Investigation of choice in the children, it is going to be USG. So what is going to be the features of the erect abdomen? Erect abdomen features enna paapengana, air fluid level. You're going to see air fluid levels. So air fluid levels more than 3 is going to suggest, it is going to suggest obstruction. It is going to suggest obstruction. Very, very important point you need to understand. So then the air fluid level more than 3 suggests obstruction. Again, in the investigation on the supine X-ray வந்து பாத்தீங்கன்னா ஒவ்வொரு இடத்துல ஒரு மாதிரி features cause பண்ணும். Okay, so for example, if you're going to take erect X-ray, if there is going to be air fluid level at the level of okay, நீங்க இப்ப சுப்பைன்ல பாக்குறீங்க. So first நீங்க இது எரெக்ட்ல எடுக்கிறீங்க. எரெக்ட்ல எடுத்தா உங்களுக்கு வந்து அப்ஸ்ட்ரக்ஷன் இருக்கான்னு தான் தெரியும். But why I am also taking supine? So supine positionல why I am taking is to know the site of obstruction, to know the site of obstruction. What is the site of obstruction? I'm going to identify from this. So whether it is going to present in the jejunum, whether it is present in the jejunum, or whether it is present in the ileum, or whether it is present in the large bowel, whether it's present in the large bowel, I will be able to differentiate it with the supine X-ray. How I am going to differentiate? If it is jejunum, I am going to get a feathery appearance. I'm going to get a feathery appearance. So a feathery appearance, this is going to be suggesting of a complete volvulus. Like you can. What is ileum? So ileum, it is going to be featureless. Ileum, it will be featureless. It will be featureless in ileum. And how will it be in the large bowel? In large bowel, there is going to be a incomplete ostrations. Incomplete ostrations you can find. So let me show you one by one. Okay, let me show you one by one. Where is the image? See here. So this is going to be your what is this? This is going to be air level. So you're going to have air fluid level. So in the X-ray, you're going to have air fluid level at 1. So you're going to experience the air fluid level at different places. Okay, you're going to experience air fluid level at different places. What are the places you're going to experience air fluid level? Number 1, let's see one by one. Okay, first when you're going to see the air fluid level, okay, when you're going to see the air fluid level at the level of, okay, 1, you're going to have 1 more here, you're going to have 1 more here, you're going to have 1 more here, you're going to have 1 more. So more than 3. So when you're going to have more than 3 air fluid level, it suggests of obstruction. It is going to suggestive of obstruction. This is the first thing which we can understand from this. In this, can you see here? In this, what you can see? You can see a feathery appearance. Can you see here? You can see a feathery appearance. So what is this feathery appearance suggestive of? Feathery appearance suggestive of incomplete volvulus. Feathery appearance is going to suggest of incomplete volvulus. Okay. Feathery appearance. So feathery appearance suggests complete volvulus. Ilial loop featureless. So ilial loops are the featureless. This features. So what is this? Can you see here? What is this? This is going to be a incomplete ostrations. Can you see here? So this is going to be having a incomplete ostrations, and this is going to suggest what? This is going to suggest large bowel obstruction. Large bowel. Okay, what you can see? You can see a large bowel obstruction. Okay. Large bowel obstruction. Is it clear? Okay. So now we have discussed about the site of obstruction. Now we have discussed about certain investigations. How do you manage these patients? So now the question is, how we are going to manage these patients? So initial management in Pathona, how we are going to manage is number 1, start with NPO. Okay, then what you're going to do, you're going to go IV fluids. Then what you're going to do, you're going to give IV fluids for the patients. So IV fluids you're going to give for the patient. IV fluids na enna kudupinga, what IV fluids you will be prescribing. So you will be prescribing IV fluids not directly. Okay, IV fluids prescribe பண்ணலாம். அதுக்கப்புறம் IV fluids அப்புறம் ரொம்ப important என்னன்னா, we have to prescribe the Ryle's tube. So Ryle's tube போடணும் பேஷண்ட்டுக்கு. Okay, Ryle's tube போடணும். ஏன் Ryle's tube போடலாம்? You can also go for NG tube. NG tube or you can go for Ryle's tube. Why you give for Ryle's tube and IV tube is okay. So நம்ம சாப்பாடு வந்து அது வழியா தான் உள்ள அனுப்பணும். So then you can go for the fourth one, that is going to be IV antibiotic. IV antibiotic you're going to give. IV antibiotic such that you're going to give such that it is going to cover both aerobe as well as anaerobe. Then you can give for IV painkillers. IV painkillers can be given. After IV painkillers, finally you can go towards the surgery. Very important. What surgery you're going to perform? Anyone, any idea? In case surgery is required, what you will be doing? If the conservative management is failed, you go for surgery. So how do you perform the surgery? So before surgery, first structure which is visualized, you need to understand. What is going to be the first structure? First structure that is going to be visualized. That is going to be visualized. Understand, the first structure which is going to be visualized is your cecum. First structure that is going to be visualized is your cecum. So cecum பாக்குறப்ப என்ன ரெண்டு விஷயம் பாக்குறீங்கன்னா, ஒன்னு is the cecum collapsed. You're going to see whether the cecum is collapsed or whether the cecum is distended. So whether the cecum is collapsed or whether the cecum is distended, you're going to see. Okay, so cecum collapsed இருக்கா இல்ல cecum distended இருக்கான்னு பாக்குறீங்க. Collapsed ஆனதுன்னா you go for it. This is nothing but small bowel obstruction. It is small bowel obstruction. If the cecum is distended, then it is going to be large bowel obstruction. It is easy. Now you will be able to identify which is going to be the obstruction area. Okay, so obstruction area கண்டுபிடிச்சிட்டீங்க. So now once you found out the obstruction area, next what you are going to do, you are going to see whether it is going. So obstruction area கண்டுபிடிச்சிட்டீங்கன்னா அதை நீங்க ட்ரீட் பண்ணிடுவீங்க. That's all. This is the initial management. Okay, so there are various causes of obstruction basically. So இங்க நம்ம generalized obstruction இருந்தா என்ன மேனேஜ் பண்றோம் நம்ம பார்க்கிறோம். But there are various causes of obstruction. It can be duodenal atresia, it can be jejunal atresia, it can be it can be interstitial. So my various causes இருக்கு. Let's see one by one. Number one, there can be duodenal obstruction, duodenal atresia, duodenal atresia. Okay, so duodenal atresia. What is this duodenal atresia? It is the most common cause of obstruction. Is the most common cause of obstruction in neonates. How do the x-ray look like? So before showing x-ray itself, I'll tell you this is going to be your spinal cord. Just see here, this is going to be a spinal cord. So spinal cord order structures தெரியும். So you're going to have your rib like this. Okay, you're going to have your rib like this, isn't it? So இங்க வந்து பாத்தீங்கன்னா you will be having a double bubble sign. So இந்த மாதிரி உங்களுக்கு ஒரு இது இருக்கும். So if this is going to be your papa இந்த மாதிரி இருந்ததுன்னா, I'm just drawing a roughly pa. Okay, so if this is your baby na, what your x-ray erect x-ray la what you are going to see in erect x-ray. So இது வந்து அப்படியே continue ஆகி, so this is your spine, this is going to be your okay pelvic. So this is going to be your pelvic. Okay, this is going to be a pelvic. Just think that this is your pelvis. So what happens is there is going to be a obstruction. There is going to be a obstruction. Now what happens? You're going to have a double bubble sign. So this is called as double bubble sign. So double bubble sign on x-ray. Okay, again I repeat. So what you're going to have? You're going to have a double bubble sign. Double bubble sign on x-ray. Okay, very important. So this is the most common cause of obstruction in the neonates, and this is common in Down syndrome. This is common in Down syndrome. Okay, so what are going to be the clinical features? Clinical features are bilious vomiting since birth. Number one, it is going to be bilious vomiting since birth. Okay, then what is going to be the x-ray finding? You're going to see here x-ray finding. I already told you x-ray finding is going to be double bubble sign. And then what is going to be your management? So management in this case is going to be your duodenal duodenostomy. So what is going to be the thing you're going to do? Duodenostomy. So this is going to be your duodenal atresia. The thing what you're going to do in duodenal atresia. Okay, next what we are going to discuss? We are going to discuss about the jejunal atresia. Jejunal atresia. So what happens? What you're going to see in the jejunal atresia? In jejunal atresia, instead of double bubble sign, so idhe maye or X-ray edukonga. Just see. So this is going to be your spine of the baby. Okay, this is going to be a spine of the baby. Erect, okay, erect spine. So this is going to be your structure visualized. So what happens here? You're going to have your lung field. Okay, so this is going to be your lung field. Okay, this is going to be your lung field. Particularly, you're going to have lung field like this. Okay, art இங்க இருக்கும். So இது வந்து உங்களோட lung field. Okay, so என்ன ஆகும்னா இந்த இடத்துல you're going to have 1, 2, then you're going to have 3. So this is how your sign will be. Okay, this is how you're going to get. So you're going to have 1. Okay, you're going to have 2, you're going to have 3 bubbles. Okay, 3 bubbles darker or so how this is going to be that darker. So surrounding areas light color la irukum. So in the area mattum dark color irukum. This is going to be a triple bubble sign. So where do you see double bubble sign? In the duodenal atresia. Where do you see triple bubble sign? You're going to see in the jejunal atresia. So in jejunal atresia you're going to see triple bubble sign. So very important. So remember, triple bubble sign is going to be seen in the chest X-ray. You're going to see in the erect abdomen X-ray. Triple bubble sign on X-ray. This is what you're going to get in the jejunal atresia. So what is going to be in the jejunal atresia? You're going to have you're going to have type 3B and type 4. Okay, type 3B and type 4 like you're going to have specific feature. I'm just telling you important points alone. Type 3B like you're going to have a apple tree or Christmas tree appearance, Christmas tree deformity, okay, with mesenteric gap. Other type 4 like you're going to have a string of sausage appearance. So string of sausage appearance. So இது எதுக்காக நான் இது சொல்றேன்னா ஒரு MCQ கேக்குறாங்க உங்களுக்கு apple tree or chronic Christmas tree deformity is seen in which type of atresia? Jejunal atresia type 3B specific சொல்லணும். Multiple atresia with string of sausage appearance you're going to see in type 4 of jejunal atresia. Okay, very clear. Next we are going to move towards the intersusception. We are going to talk about intersusception. Can you talk about the intersusception? You need a break? No. I will complete intersusception. Okay, we'll complete intersusception. We'll complete the volvulus. And after completing the volvulus, we will go for a break. Until then, I think we have to hold down our break. So we have to complete these 2 topics at least before completing this session of today. Okay, already we are extending the day. For esophagus itself, we took 2 days. Then we took stomach 2 days. And this is the 5th day. I don't want to extend further. So let's talk about intersusception. So intersusception is of 2 types, primary, secondary. So you're going to have primary intersusception, secondary intersusception. Before moving to that, what is intersusception? Intersusception is nothing but it is going to be telescoping. It is telescoping of one bowel. Okay, telescoping of one bowel loop into another. Okay, so for example, this is going to be your okay, this is going to be your intestine, isn't it? So what happens basically is this is going to be a large intestine. So a large intestine, I'm just drawing in a reverse way. Wait a minute. I'll just draw in a straight way. So this is going to be your so you're going to be ascending colon. This is going to be your sigmoid. Okay, this is going to be your sigmoid. You're going to have appendix. Here you're going to have your jejunum. So what happens is there is going to be a inversion. There is going to be a, okay, what happens? So see here, there is going to be a somewhat like this. It is going to get inverted. So somewhat it is going to get inside. Okay, there is a loop. Okay, telescoping of one bowel loop into another. So there is a, which is going to be the loop that is going to be descending inside your ileum. It is going to enter into your ileum is going to enter into your colon. So colon is going to be intersusceptions. So your colon, we call it as intersusceptions. Okay, recipient. So who is going to be the donor here? your small intestine, that is going to be your interseptum. So who is your interseptum? It is going to be your small intestine. So because of this, what happens is, okay, at this point there is going to be a narrow region, narrowing. So at this point what happens is your neck, at this point it is very narrow, at this point it is very narrow, that you need to understand. Okay, well, so there are two different types of intersusception, guys. What are the two types of intersusception? You have primary intersusception, you have primary intersusception, you have secondary intersusception. Primary intersusception is more than your secondary intersusception. Primary is commonly seen in children. Primary you are going to see commonly in children. So age group 6 months to 2 years. So what happens here? There is going to be a hypertrophy of Peyer's patches. Hypertrophy of Peyer's patch. There's hypertrophy of Peyer's patch leads to ileocolic. Okay, it's going to cause ileocolic. And in adult, what happens? In adults is going to be mainly secondary. Secondary level, this is going to be due to some pathological lead point. So what is the pathological lead point? Most commonly it is going to be your polyp. Most commonly, okay, so most commonly there can be some polyp, okay, or there can be diverticulum or cancer. So secondary cause you're going to have three. Most common polyp, diverticulum, cancer. Okay, well, so this year what happens is, this is going to be most commonly colic. So most commonly this is going to be colic. Okay, wow. So what is going to be the clinical features? What is going to be the signs? So clinical features, I'll tell you. Features of intestinal obstruction. Number one, in children. So clinical features, let's see. Clinical features and signs. So features of intestinal obstruction. What are the clinical features you're going to see in the intestinal obstruction? Number one, in children, if you're going to take, primary, there is going to be red currant jelly stools. Okay, we're going to get red currant jelly stools. So it's going to be a blood mixed with sputum. So what is your red currant jelly stools? This is going to be a blood which is going to be mixed with mucus. Okay, wow. So this is going to be a red recurrent, and there is going to be a sign of dance. What is a sign of dance? So you're going to have like this. Okay, just draw your abdomen like this. So you're going to have this particular place is going to be empty. So this is going to be empty place. So this is going to be empty place. And you're going to have a lump which is felt in the right lumbar region. So in the right lumbar region, in the இடத்துல what happens? You're going to feel a lump. Okay, you're going to feel a lump over here. So this is going to be a right lumbar fossa. You're going to feel a lump. This is called as sign of dance. What is this called as? It's called as sign of dance. Very important, very important. Just remember. Next, you're going to have investigations. What is going to be the investigations you're going to perform here? Okay, investigations you're going to perform is going to be, initially you're going to go for X-ray. So initial investigation we go for X-ray abdomen erect and supine. Okay, but investigation of choice in children it is going to be, this is going to be USG. In children you go for USG, but in adult you go for the CECT. Sorry, USG you're going to see target sign, or you'll be seeing a donut sign. This is what you're going to see. Then you can go for contrast enema. In contrast enema, what do you see, guys? In contrast enema, you're going to see a pincer or claw sign. So what is pincer? What is claw sign? Just if you remember, okay, so the developmental milestones, if you're going to see, we will have this pincer. Pincer na ida pincer graft, immature pincer, mature pincer. So and the madri ungalku irukum. Plus, you will also note another important point, that is going to be claw sign. So this is your claw, right? So you will have a claw sign or a pincer sign. So that is what they basically want to tell. Okay, so that is your pincer, claw, and so what is going to be it is going to be both diagnostic and therapeutic. So this contrast enema, it is going to be acting both as a diagnostic as well as therapeutic. It is going to be a diagnostic as well as therapeutic. Okay, so what is going to be the contraindication of this contrast enema? Do you even know contrast enema? Contraindication number one, if there is going to be any perforation 100% you cannot give contrast. Number 2, if there is a strangulation you cannot give. And number 3, any pathological lead point you cannot give contrast anymore. Okay, so this is going to be done. Okay, when do you go for a surgery? You have to remember that. So when do you go for surgery? So that is going to be your indications of surgery. Remember, the indications of surgery are number 1, secondary to pathological lead point, or whenever there is going to be bowel perforation, or whenever there is going to be a recurrent intersusception, then you go for the surgery. This is a very important point you need to understand. Now let's see the pictures, x-rays, and then come back. So this is going to be an intersusception. So in adults it is caused by polyp or tumor. It's going to be all intersusception happens when the ileum fold into your cecum. So what happens? This is going to be your, can someone understand? Can someone tell me what is this? So this is going to be the X-ray finding in your intersusception. So intersusception intestine will be coming inside. It is going to be going inside here. And there is one more thing that is called as coffee bean appearance, which you will be seeing later. And this is going to be, again, this point is very important. So this is important point. So you can see a target sign. Can you see here? So you can see a target sign. Can you see here? So this is going to be your target sign, or you can otherwise called as donut sign. Okay, so then what is this? This is going to be your claw sign. Can you see here? So this looks like a big claw, right? This looks like a claw. So that's why you call it as claw sign. Okay, this is going to be your coffee bean appearance. This is going to be your coffee bean appearance. ரொம்ப important. So x-rays, these are. So coffee bean appearance. Coffee bean appearance pakala. Again, you see in the condition valvulus, intersusception. You will see. So this is going to be the next important topic which we are going to discuss. We are going to discuss about valvulus. What is this valvulus? Valvulus na enna? Okay, onnume illa. So coffee bean appearance enga paapom? It is not in your intersusception, guys. Coffee bean appearance you will see in the valvulus. Okay, you will see in the valvulus. Intersusception la neenga idhaan paapinga. So how this looks like. This is going to be the one that you find in the intersusception. Okay, valvulus la you will find like this. Okay, coffee bean appearance. Valvulus la what you will find? You will find a coffee bean appearance. Okay, very important. So that is what we are going to discuss now about the coffee bean appearance. Can we discuss? Yes. So now we are going to talk about the next important thing that is going to be your valvulus. Okay, so valvulus in pathona rendu important irukku. Okay, so either it can be sigmoid valvulus, either it is going to be a sigmoid valvulus, or it is going to be a cecal valvulus. Sigmoid valvulus pati paapom. Illana we will see about the cecal valvulus, sigmoid valvulus or cecal valvulus. Sigmoid valvulus, what are the predisposing factors? Sigmoid valvulus or a predisposing factor, number 1, long and narrow mesentery. Long and narrow mesentery. Number 2, reductant sigmoid. Number 3, loaded sigmoid. Okay, so whenever there is a long narrow mesentery, whenever there is a redundant sigmoid, whenever there is a loaded sigmoid, so these predisposes to the sigmoid valvulus. What are the commonly seen in patient? So this is commonly seen in the antipsychotic medication. The patient who are going to take, this is most commonly seen in 2 type of patient. One, antipsychotic medication, and patient who is going to have a chronic constipation. Okay, so there will be a sigmoid valvulus. So now I am going to talk about the sigmoid valvulus alone. So in sigmoid valvulus, what all you are discussed is this one. And what is going to be the very important point is going to be anti-clockwise rotation is more common. Clockwise rotation is more common than clockwise rotation. ஒண்ணுமே இல்ல, இங்க என்ன நடக்குது அப்படின்னு நீங்க அண்டர்ஸ்டாண்ட் பண்ணீங்கன்னா போதும். ஒரு இன்டெஸ்டைன் இருக்குல்ல, அந்த இன்டெஸ்டைன் சுத்திக்குது வால்வுலஸ். சோ நம்ம கேஸ்ட்ரிக், நம்ம வந்து பாத்தீங்கன்னா ஆல்ரெடி we have seen about the gastric outlet obstruction. நம்ம gastric outlet obstruction பார்த்தோம். Do you remember? So we have seen certain gastric outlet obstruction. So the gastric outlet obstruction pakumbodhu, I have told you a very important thing, what it is. So there are some gastric outlet obstruction where there is going to be a gastric outlet enna pannum valve la suthikum twist aaikum. So na the word use panna correct, there is a twisting. So I told you, right, there is going to be a twisting of your gastric stomach. So adu vandu gastric la nama paathom, gastric volvulus la. So anga paatha important ana clinical feature enna, Borchardt triad. What is Borchardt triad? Abdominal pain, retching. So there is going to be a unproductive retching and inability to insert your Ryle's tube. Again, I repeat, what are the three things which you are going to, we have seen in the Borchardt triad, which is present in the gastric volvulus. Number one, abdominal pain. Number two, unproductive retching. Number three, inability to insert your Ryle's tube. Okay, va? There is going to be twitching, but twitching is going to be occurring in the intestine. So in the twitching of intestine வந்து பாத்தீங்கன்னா sigmoid valve, sigmoid twitch ஆகலாம். அப்படி இல்லனா உங்களோட சீக்கம் twist ஆகலாம். சிக்மாய்டுங்கிறது ஈலியம். ஓகேவா? சோ sigmoid colon வந்து twitch ஆகுது. Sigmoid colon twitch ஆச்சுன்னா that is going to be giving rise to what? Coffee bean appearance. நம்ம பார்த்தோம்ல ஒரு x-ray. So அந்த coffee bean appearance எங்க நம்ம பார்க்கலாம்? Coffee bean appearance is seen in the x-ray. So now tell me, investigation of choice. What is going to be the investigation you are going to perform? Investigation is going to be x-ray. So x-ray erected thing, what you can see? You can see a coffee bean appearance. Coffee bean appearance can be there. You can see a dilated large bowel. Dilated large bowel can be seen. And number three, you can see ostrations. Ostrations can be seen. Okay, very important. So in the contrast enema. So we are going to give a contrast enema. Contrast enema, what is the sign you are going to see? Contrast enema. What is going to be the sign you are going to see? There is going to be bird beak appearance. Bird beak appearance. Now I am again asking you, in which condition? We have discussed this bird beak appearance already. So there was one condition where we discussed bird beak appearance already. Can you tell me what is the condition where we discussed about the bird beak appearance? Yes, come on, you can do it. Yes, what is going to be the bird beak appearance? Where did we see bird beak appearance? We have seen in some bird beak appearance, achalasia cardia. In achalasia cardia also you get bird beak appearance. Again in your sigmoid volvulus also you're going to see bird beak appearance. So what are the two places where you see bird beak appearance? Again, repeat along with me. You're going to see it in the sigmoid volvulus. You're going to see it in the achalasia cardia. What is the appearance which you're going to see in the carcinoma esophagus? You're going to get a shouldering effect, rat tail appearance. Rat tail appearance, otherwise called as apple core appearance. Very clear, right? Do you have any doubt till now? If you have any doubt, let me know. Now we are going to move towards, we are going to move forward. What is going to be the management for this patient? So what is going to be the management you're going to do for this patient? So whenever there is going to be a sigmoid volvulus, what you're going to do? So you're going to see whether the patient is stable, whether the patient is unstable. You're going to divide into stable, unstable. So the patient is stable, there is stable, that means that there is no peritonitis. Okay, wow. So there is no peritonitis. Then what you're going to do? Then you're going to do a sigmoidoscopic compression. Decompression. You're going to do sigmoidoscopic decompression. Okay, wow. So what is going to be a definitive surgery you're going to perform? So the definitive surgery is going to be for this patient. Definitive surgery is going to be, what is your definitive surgery? Sigmoidectomy. Okay, so that you do for stable patient without peritonitis. If the patient is unstable and the patient is having peritonitis, what will you do? You go for Hartmann procedure. Hartmann's procedure. What do you do in Hartmann procedure? There you're going to resect the perforated segment. Number one, you're going to resect the perforated segment. Number one. And number two, you're going to do a proximal colostomy. And number three, you do distal end closure. closure, and you're going to keep it inside. You're going to keep it inside. This is going to be your sigmoid volvulus. This is what you're going to perform in case of your sigmoid volvulus. Is it clear, guys? If you are clear about the sigmoid volvulus, next we are going to talk about the very important second one, that is going to be your cecum volvulus. So what happens in your cecum volvulus? Remember, in a cecum volvulus, so it is going to be more common in the female. This is going to be more common in the female compared to that of your male, and this is going to be arising in the 4th and 5th decade. This arises in the 4th and 5th decade, and you're going to have a mobile cecum. You're going to have mobile cecum, and this is going to rotate. The one previously we discussed, sigmoid colon, that rotates in a anti-clockwise direction, whereas this rotates in a clockwise direction more than anti-clockwise direction. This is very important. And what is going to be your clinical features? Number 1, you're going to have vomiting. Number 2, you're going to have obstipation. So constipation plus flatus, that is called as obstipation. Okay, very similar to that of your bowel obstruction. And what is going to be investigation you're going to perform? Investigation you're going to perform is, initially you're going to go for X-ray. Initially you're going to go for X-ray abdomen, but investigation of choice is going to be CECT. Investigation of choice is going to be CECT. Okay, how do you manage these patients? Now we are going to move towards the management. Now we are going to talk about the management of these patients. Okay, how do you manage these patients? Very easy. So management of these patients are going to be, okay, first similarly you're going to see whether the patient is having peritonitis, no peritonitis, whether the patient is having peritonitis. Okay, you're going to divide whether there is peritonitis or whether there is no peritonitis. You're going to just divide. If there is no peritonitis, there is no role for colonoscopy. There is no role for colonoscopy. ரொம்ப important. Okay, if then you're going to have surgery. Okay, then you're going to do surgery. What type of surgery do you perform? There are 2 types of surgery here, right? Okay, number 1, cacopexy. Number 2, right hemicolectomy. Okay, number 1 colcopexy, number 2 right hemicolectomy. Okay, so what happens in your peritonitis or strangulation? There is going to be again right hemicolectomy, that is going to be present. Now let's see about what are the different causes of compound valvulus. Compound valvulus na ileum sigmoid. Okay, there is going to be knotting. So this causes long pelvic mesocolon. Ileum rotates around your sigmoid. So what happens here? Your ileum is going to be rotating along your sigmoid. Okay, so with this we are completing a very important part, that is going to be your volvulus. Next we are going to move towards the next part, that is going to be your strictures. Can we start with strictures, guys? Yes, we are going to start with the strictures. I think volvulus is over. So this is going to be your cecal valvulus and your sigmoid valvulus. In sigmoid valvulus, you're going to have coffee bean appearance. In your cecal valvulus, you're going to see stack of coins appearance. Okay, so stack of coins appearance. You're going to see stack of coins appearance. Then what you're going to move towards, you're going to talk about. Okay, so next, this is going to be your, what is this? Can someone? Yes, bird peak appearance. There will be a bird peak appearance. Now, after talking about all these things, we are going to move towards the next important topic, that is going to be your strictures. Okay, shall we move towards your strictures? Yes, strictures like no operation. Can someone tell me what is the surgery? Yes, this is going to be your Heinke. This is going to be your Heinke Mikulis surgery. Heinke's Mikulis surgery. I will tell you what it is. Okay, now we are going to talk about the strictures. Remember, intestinal strictures. It is caused by, what are going to be the causes of intestinal stricture? Number 1, it is going to be cancer. Number 2, post radiotherapy. Number 3, TB. And number 4 is going to be your Crohn's disease. Okay, what are the 4 things? Cancer, post radiotherapy, TB, and your Crohn's disease. What is going to be a management, guys? Management is going to be, if strictures are 2 types. Okay, if it is going to be close to each other, if it is going to be close to each other, then this is going to be resection and anastomosis. Resection and anastomosis. And what is the second thing? When it was going to be far apart. When it is far apart, it is going to lead to structuroplasty. This is very important. Okay. So what are the types of structuroplasty? So there are two types of structuroplasty basically. Number one is going to be your Heinke Mikulicz disease, and that's a surgery. That is second thing is going to be Fenny. So Heinke Mikulicz enna பண்ணுவோம்னா longitudinal incision and you're going to suture it transversely. So you're going to put a longitudinal incision and suture transversely. Whereas in Fenny, what you're going to do is you're going to do a side-to-side incision, side-to-side anastomosis of the bowel. You're going to do a side-to-side anastomosis of the bowel. Okay, I'll show you the picture once again. Now you can identify. This is called as Heinke Mikulicz syndrome, Mikulicz type of surgery. Is it visible, guys? I think there is a problem. I think many people couldn't visualize. Can you see? Yes. So this is your Heinke Mikulicz. So here what happens here? You're going to put a longitudinal incision. You're going to put a longitudinal incision and you're going to suture it transversely. So longitudinal incision போடுறோம். ஆனா suturing எப்படி பண்றோம்? Transverse suturing is done. Can you see here? Yes. So this is called as Heinke Mikulicz. This is called as Heinke Mikulicz. Now I hope so you can understand. Now we are going to move towards the next important thing. That is going to be, this is your atresia. Can you see here? This is your duodenal atresia. So polyhydramnios clinical features at birth. So X-ray la double bubble sign. Can you see here? This is your bubble. Okay, you have two bubbles actually. Okay, just imagine this as a two bubbles. Okay, what are the two bubbles? Number one, this is going to be one bubble. Okay, this is going to be other bubble. This is going to be a double bubble sign. Okay, you have different types actually. So type 1, so jejunal atresia, triple bubble sign you can see. So this is going to be a triple bubble sign. You can have type 1, membrane only. In type 2, what happens? Fibrous cord like it's going to be there. And type 3, it's going to be a complete interruption. There's going to be a complete interruption. Okay, this is what I want you all to understand. And next is going to be your adhesive intestinal obstruction. So what happens in your adhesive intestinal obstruction? Just write it down. So adhesive intestinal obstruction. Adhesive intestinal obstruction. So what happens in adhesive intestinal obstruction, guys? Number one, it is going to be the most common cause of bowel obstruction. Even though we have discussed everything, this is going to be the most common bowel obstruction. This is going to be the most common bowel obstruction that you need to understand. And this is going to be two variants. So either it is going to be post-surgery or non-surgical cause. Non-surgical causes. If it is going to be non-surgical cause, what are the causes? Number one, it can be Crohn's disease. Okay. Number two, TB. Number three, endometriosis. Number four, when it is PID. And number five, post-radiotherapy. Okay, ba? So CECT is done to rule out. Why do you do CECT? CECT is done to rule out other causes. Okay, it is done to rule out other causes. So what is going to be a management? So management is going to be very important. It's a conservative management. So conservative management. 28 to 48 hours. So majority will be resolving spontaneously. Okay, well, if adhesiolysis is done, so remember, majority is going to resolve spontaneously. And if adhesiolysis is done, if adhesiolysis done, it itself is going to lead to more adhesion. So நீங்க வந்து adhesiolysis பண்ணீங்கன்னா ஓகேவா, so நீங்க என்ன ஆகும், that will be causing more adhesions and it can complicate your process. So they can complicate your treatment. That is why adhesiolysis is not done. And last but not least, you're going to have the last part, that is going to be your Latz band. What is the Latz band? So a Latz band is the most common internal malrotation abnormality. It's a most common internal malrotation abnormality. So can you see here a band? Okay, so it's going to be right hypochondrium length, டியோடனல் அப்ஸ்ட்ரக்ட் ஆகி சீக்கம் போகும். ரைட் ஹைப்போகோண்ட்ரியம்ல இருந்து அது அப்படியே போய் சீக்கம்ல ஜாயின் ஆகும். ஸோ இட் இஸ் கோயிங் டு பி ஸ்டார்டிங் லைக் திஸ், ரைட் ஹைப்போகோண்ட்ரியம் டு சீக்கம். ஸோ மேல் ரொட்டேஷன். ஸோ இட்ஸ் கோயிங் டு பி கமிங், இது நார்மலா இப்படி இருக்கணும். அதுக்கு பதிலா என்ன ஆகுதுன்னா உங்களோட இந்த what to say, this one cecum is going to be mal rotated. It is going to be present in the right hypochondrium. So that is going to lead to Latz band. How do you manage this? So management is going to be excision. This is going to be, how do you manage this patient? So management is going to be excision. Excision of the Latz band, of this Latz band. Okay, so with this we are completing this session. In the next session, day 6 over. Okay, in the day 7 tomorrow we are going to continue with day 6. In day 5 day 6 we will be starting with the Merkel's diverticulum, a very important topic again. Merkel's diverticulum, SMA syndrome, then we will discuss about Hirschsprung disease. Okay, all these things in the next session. Okay, thank you so much.